Dear audience, I would like to present you today my PhD topic, Management of Intraoral Halitosis. My name is Eszter Szalai. My vision is to find and bring the best solution for diagnostic and managing halitosis. To reach my vision, my mission is to contribute to oral health and well-being by providing the best care to every patient. These are my first steps how I would like to achieve my vision. 2 of my projects are investigating the effectiveness of chlorine dioxide, and other 2 projects try to improve the diagnosis of intraoral halitosis. My first project, daily use of chlorine dioxide effectively treats halitosis, a meta-analysis of randomized control trials. 60% of the world population has experienced halitosis, and 90% of all cases originated from the oral cavity. We spend billions of dollars a year on anti-malodor mouthwashes, but we still don't know which is the best. Chlorhexidine considered as the gold standard, but they have several side effects. So, our aim to investigate the effectiveness of chlorine dioxide in halitosis, which has unknown or a few side effects. Consequently, our clinical question, how do chlorine dioxide containing mouthwashes influence the level of halitosis? We would like to compare the chlorine dioxide to other mouthwashes or placebo. Our primary outcome, the changes on the organoleptic testing scores and on the volatile sulfur compounds. After our systematic search, we find 10 eligible articles, and I would like to present our main outcomes, the changes of the organoleptic measurement within the baseline and within the 1 day and the 1 week data. The first forest plot shows us the 1 day data, and the second 1 week data. Organoleptic measurements mean that the tester smells the patient's breath and evaluates from 0 to 5, 0 when it's normal odor and 5 when it's very severe. We can see that we find statistically significant differences in both cases, but clinically relevant in the 1 day data. When we move to the objective measurement of the halitosis, which is the volatile sulfur compounds measurement, we find that the most important data with the hydrogen sulfide, which is good for us because hydrogen sulfide is the main component of intraoral halitosis, and chlorine dioxide effectively reduces it. The main strengths of our meta-analysis, all of the included studies are randomized controlled trials, and the results of the organoleptic measurements in more time points. We have a few limitations, the small number of included studies, and we find just one article with the chlorhexidine comparator, and we couldn't perform a meta-analysis from this, just with the placebo. And this is our research implication that we would like to suggest researchers to make more studies with this kind of comparator. As a main conclusion, that we think that chlorine dioxide mouthwashes should receive a more prominent role in the therapy of intraoral halitosis based on our results. Our first manuscript is accepted in the Journal of PLOS One. Our second project, organoleptic and halitometric assessments don't correlate well in intraoral halitosis, is also a systematic review and meta-analysis. As I mentioned, the most used method, the organoleptic measurement, this is the gold standard, easy to perform but subjective, unreliable, as it's visible on the fixture, and uncomfortable for the tester and the testee. Other methods also exist. They are the ultramarauder measuring devices. They considered as objective, the results repeatable and reproducible. Here is visible the most used devices, the halimeters and the oral chromas. Most of the researchers used more than one method to make a diagnosis, but we think it's time-consuming, so our aim to standardize protocol for clinical research into oral malodor. Our next clinical question, which of the volatile sulfur compounds measuring devices is the most suitable for measuring halitosis? Our reference standard, the organoleptic measurement, and we would like to compare as an index test the oral malodor measuring devices. Our primary outcome, the correlation coefficient, and the secondary, the sensitivity and the specificity of the devices. Our hypothesis, the halitosis measuring device is as appropriate as the organoleptic method to measure the level of halitosis. After our systematic search, we find 75 eligible articles. And the most important data about the correlation, the gas chromatograph showed the best correlation with the organoleptic measurement. It was 0.76. None of the devices is significantly superior to the others, but we would like to suggest to researchers use gas chromatograph. When we performed the subgroup analysis, we realized that the significant difference in the correlation between the inclusion and exclusion of the patients with extraoral diseases in case of halimeter devices. We also would like to suggest to clinicians that exclude patients with extraoral halitosis in the case of halimeter devices. Our secondary outcome was the sensitivity and the specificity of the devices. It's visible that none of the devices is significantly superior also to the others in the sensitivity data, and none of the devices' sensitivity are outstanding. Roughly means that 80% of the patients can be correctly diagnosed with these devices. As a research implication, we would like to suggest to make more diagnostic test accuracy and need to investigate that organoleptic measurements is a true gold standard or not. The main conclusion, organoleptic measurements seems that it is still the gold standard measurement despite of disadvantages, and newer devices need to be investigated because may it exist, just not widespreadly used. Our second manuscript is also accepted, and it's available online in the Journal of Evidence-Based Dental Practice. After our first project, we decided we would like to perform another trial. It's named ODOR trial. It's a double-blind, two- and parallel non-inferiority pilot randomized control trial to investigate the effect of hyperpure chlorine dioxide on intraoral halitosis. It's a protocol, and we would like to compare the hyperpure chlorine dioxide to the chlorhexidine mouthwash in intraoral halitosis, and our primary outcome will be the changes on the organoleptic testing course. Our hypothesis that hyperpure chlorine dioxide containing mouthwash is not inferior to the chlorhexidine in intraoral halitosis. If our hypothesis is true, it will decrease the intraoral halitosis and its consequences. We are ready with the first version of our protocol. Here it's visible our inclusion and exclusion criteria. It's our participant timeline, and this study will be a short study because of the nature of will be a pilot. So it's a 3 hours long study, and we would like to perform the organoleptic measurement, gas chromatographic measurement, and also the self-perceived halitosis in every time. We also ready with the case report forms. And last week we had the International Advisory Board discussion also, and now we are phasing the preparation of the documents, Hungarian and the ethical approval. Here is visible my additional activities related or topic. And as a summary, I would like to finish our third and fourth project in this summer. And thank you for your attention. The first and the greatest victory is conquer yourself from Beto.
Thank you for your presentation. You mentioned in your first topic introduction that in 90% of halitosis cases, it is oral origin. How can you differentiate it if it is really oral or something else, and what are the other origins of halitosis?
Thank you for your question. So usually there are two methods, the cysteine induction methods, that it means that the patient rinse with the cysteine, and if it's elevated the intraoral halitosis, it means it's the intraoral origin, or the researcher can smell also the breath of the nasal breath, and if just the nasal breath is uncomfortable, it means that it's not oral origin.
And in the case of not oral origins, what else can be origin?
So it can be originated from the lungs or the stomach, or there is blood-borne halitosis also.
What was the third one?
Blood-borne halitosis.
And in these other cases, what can be the treatment for the patient?
Need to send to specialists, for example, internal medicine specialists, and they have to treat the other problems also, because usually it's a systematic disease problem.
Congratulations. My question is related to the previous question. So I just wanted to ask if in your first study the reason for halitosis was reported, and was it like different across the studies? And could it influence the results or the efficacy of the supplements used?
Yes, so of course it can be present together, the intraoral and extraoral halitosis, but with questionnaires also, and to evaluate the nasal breath, usually studies try to exclude it. So in some cases it's not mentioned, but yes, it can be a bias also.
Congratulations, Eszter, on your nice presentation. My only question is regarding chlorhexidine, that could you mention any of the side effects of this material?
Yes, tooth discoloration, false taste sensation. This is the most common.
Okay, thank you.
Eszter, first of all, of course, thank you for your presentation and congratulations on both accepted manuscripts, right? As a follow-up question to Katte's question, as you said, there are some side effects, but you also said that it should be recommended as a gold standard. If the others are maybe not as good in treating the halitosis, but do not have side effects, so for which patient population would you then rather recommend the chlorhexidine, or for everyone with halitosis?
So chlorhexidine considered as the gold standard, but there is no guidelines. So I hope that after our research, the clinical trial, we can prove that chlorine dioxide is effective, and maybe after that we can suggest it better than chlorhexidine. Now I cannot state, because we just compared in our first study with just placebo.
Thank you very much. And also as a question for curiosity, what is the reason for the changes in taste sensation? Do you know this?
Not exactly.
No. But thank you very much.
Thank you. Congrats, Eszter. My question is, maybe it's a stupid question, but I wonder if the experts smells the halitosis, and it was a 0 to 5 scale, right? How can the expert calibrate it that always the 2 is 2, the 3 is 3? This is my question.
Yes, so more judges better, and in this case there is some test that both of the judges smells it, and if they can standardize it, it will be good. But yes, it's the disadvantages of this kind of measurement.
Thank you.
Sorry if my question will be a bit strange, but so I'm an outlier here among so many dentists, so many brilliant dentists, so many oral specialists. But in the recent years, we have begun to emphasize the immense importance of the microbiome at all places of the body. So this halitosis may be, one of the reasons may be a dysbacteriosis in the oral cavity. So we just use chlorine or things like that, or maybe we should try to restore the microbiome. Could it be of any help, or how do you think?
Yes, there are some studies with lactobacillus also, and so it seems not as effective as the mouthwashes, but more investigations needed, because they not compared to each other with a network meta-analysis or so on. Just we have indirect data on it.
Or maybe first the mouthwashes, and then the restoration with some bacilli.
First tongue cleaning, after mouthwashing, and
Okay. Thank you. So my colleagues from the committee.
Thanks. Please go back to the second first, but now in this case. This one, yeah. I don't understand why you had to use standardized mean difference.
Standardized mean difference usually suggested if something difference in the population, and in this case they don't use the same devices for the measurement, so this is the reason that we decided with the statistician that we will use standardized mean difference.
And how can you explain the result? It's minus 1.81.
So in this case it cannot translate it as a clinical relevance exactly, because it's not a mean difference, but it's decreasing, and it's really so substantial decrease in this part, so we think that it's important.
So you can decide that this is a clinically relevant difference.
Yes, but in this field there is no clinically meaningful difference exactly, so I cannot say that.
Okay. Thanks. And if you go to the second project, I don't need the forest plot now. I just want to ask what is the meaning of correlation?
So
And why you use this outcome?
yes, I know that the correlation is not the best type of meta-analysis because they don't show us that it's better or not the devices, but when we try to perform it, that we realize that a lot of the researchers present this kind of data, and we saw that it will be important. And our secondary outcome also, after that we will check it, but it's not as many articles as with the primary outcomes.
Okay, thanks. Excellent.
Thank you. No questions. Or just the explanations for the chlorine channels?
Chlorhexidine and sodium chloride, which is responsible for the salty taste. So disturbing the chloride channels, that's the answer.
Thank you. So the regular tongue cleaning has any positive effect in this case?
So a side effect?
That the regular tongue cleaning can reduce this malodor?
Yes, it can reuse, and this is the first treatment modality.